much, Mr. Howarth. It's a pleasure to serve under you. And I, too, would congratulate the member for Poplar and Limehouse on organising this debate. It is slightly a pity that it's less than 24 hours after the publication of the long-term plan, but people seem to have done lots of fast reading last night. Now, like others, I welcome the plan and particularly the extra funding to the NHS. But it's important to remember that what this brings it back to is 3.4%, which was the average over many years, indeed below the average over many years prior to 2010. And as the Secretary of State highlighted yesterday, with 1 million extra patients, this means that the money per head of population is actually going down. And it's something that should be looked at because it's a much better comparative measure. In Scotland, we spend £163 a head more on health than here in England, and £113 a head more on elderly social care. One of the things that we know, if we don't fix the social care side, then unfortunately any money put into the NHS is hemorrhaging out in elderly people trapped in hospital where they don't want to be. Again, we see the money focused on NHS because that sounds good to the public. But further reductions in public health, despite all the talk in the plan about prevention. And that doesn't make sense. Now, I welcome the every contact count. But in Scotland, we've had make every contact count for years. And as a breast cancer surgeon, I've discussed with all of my patients issues around smoking. Because they inevitably ask, why did I get breast cancer? Now, we don't have the answer for that, but we do have the answer for the majority of lung cancers. And I don't make them give up immediately when they're under stress, but I get them to promise me they will do it long term. And quite a number of them do. But I don't have time to support them through that journey. You still need smoking cessation services to which you can refer them. And they are being cut. And that is a problem. In the plan and in the Secretary of State's letter that he sent out yesterday, we again have a focus on cancer, which of course as a breast cancer surgeon of over 30 years I welcome. But in his letter, while he talks about early diagnosis, he doesn't talk about prevention. And yet smoking is still the biggest cause of cancer, and obesity is chasing it up as a close second. We need to tackle childhood obesity, and we need to put in a 9 p.m. watershed for advertising foods that encourage that. Now, half of us will get cancer, and as has been said by all the honourable members, early diagnosis is crucial, and particularly avoiding being diagnosed as an emergency admission. That tends to have a very poor outlook. Now, for symptomatic cancers, it is important, as the member for Shannon highlighted. Oh, I keep saying that. The member for Strangford. It's because Shannon's another body of water in Ireland. I always get mixed up. I think we'll just change it. You can be for Shannon. As the member for Strangford said, you know, it is important to know the symptoms, but both the public and indeed sometimes GPs are too focused on what are late symptoms. Weight loss, jaundice, even for some cancers, bleeding is not early enough. And we need to educate people. And what we've done in Scotland is use humour. And at the moment, there's a testicular cancer advert going on around Christmas, talking about baubles and men's baubles. And I don't care what kind of humour you need, whether it's toilet humour for bowel cancer, talking about boobs for breast cancer. If it gets people talking about it, it makes it easier for people to come forward. An audit we did many years ago in Scotland, looking at the whole patient pathway, showed that for particular cancers, and bowel cancer was one of them, actually the longest step was from the first sign or symptom to even going to the GP. So while the plan talks a lot about the pathway after going to the doctor, there's only a couple of lines about educating the populace about what to look out for, and that means we have to get people talking about it. In Scotland, we've had bowel cancer screening starting at 50 right from the beginning, and I am very sorry the member for Torfen, who's no longer in his place, obviously losing his mother in her 50s, and of course in the last year or so we've had celebrities diagnosed late with bowel cancer who might well have been picked up by having the bowel cancer screening starting at 50. Now, I welcome that last August the government committed to making that change, but neither in any announcements nor in the plan is any discussion about when it will change to 50. Now, I have to say, when I turned 50 and the poo in the post envelope landed on the mat within 2 days, I found it a bit harsh. And as my birthday's Christmas Eve, I got another one last week. And, you know, I wouldn't mind if they were a bit more sensitive, but it is something you have to do. And in Scotland, we've already changed completely to the fecal immunochemical test, which only involves one sample. And what we've already seen is an almost 10% increase in uptake. And this is, again, something the government have committed to. The rollout has been commenced, but when will it be complete? Now, what's important is to be prepared for the impact that that will have on your NHS system. If you are dropping the starting age for bowel screening from 60 to 50, you are talking about a 2/3 increase in your screening population over what you have now. If you see the same 10% increase with FIT, those two together will be an almost 3%, 3/4 increase in the colonoscopies required. And therefore, you have to be prepared with endoscopists and, as was mentioned earlier, by pathologists who will actually analyse the samples that are taken. Because in Scotland, we've seen an increase in our waiting times for colonoscopies just with the change of FIT. So it's important to be prepared. And it's similar when we're running public education campaigns. They're no use if it's just an intense campaign. Because what we found in Scotland when we did our first Detect Cancer Early is the breast cancer units across Scotland, when we audited them, had a doubling in referrals, but actually not a significant change in cancer diagnosis, because women are pretty breast aware. But you actually need to trickle those adverts throughout the year, or else the chances are there still won't be an advert when someone is sitting ignoring a symptom. Now, the other workforce, as well as endoscopists and pathologists, is radiologists. And not all radiologists can be identified as cancer radiologists. They will find cancer in all sorts of parts of the body. But this diagnostic workforce is critical. If you look at the waiting time performance all across the UK, people are struggling, particularly with the 62-day target, which in England has now fallen below 80%. But everyone is struggling with it. Yet when you look at the 31-day, which is from diagnosis to treatment, in actual fact, most cancers are over 90, and indeed most of them over 95%. So once the NHS knows you have cancer, the pathway is relatively swift after that. But it's this long gap to being diagnosed. And obviously in my own specialty of breast cancer, radiologists are critical for the initial test and investigation and follow-up. And for every 3 breast cancer radiologists who will retire in the next 5 years, they will only be replaced by 2. And the problem is breast screening came in around 1990. So all of these young consultants were appointed at almost the same time. And sadly, they're all retiring at the same time. The Clinical Radiology Workforce Report showed that the UK has a 1,000 shortfall at the moment of full-time radiologists, which will grow to 1,600 by 2022. 116 million is being spent on outsourcing and overtime. So this isn't even money, because that money would actually fund 1,300 full-time radiologists. It's we don't have the workforce. And yet in the plan, what we see, health education, again, over recent years, having had their funding cut, despite grand statements of all the extra nurses, radiographers, allied health professionals and doctors who will be trained. The plan talks a lot about IT, but instead of focusing on digital GPs, it should be focusing on internal IT. We've had electronic prescribing, referral and response letters for years in Scotland. And one of the things we do have that can help with the radiology shortage is the PAC system, where imaging is shared right across Scotland. Every hospital uses the same system. And that means is if one place is short of radiologists or is very rural An image can be sent hundreds of miles to be looked at for someone else. The plan talks about generalists, and that is needed, but you also need specialists. So the workforce plan is critical.